Hi, I'd like to welcome everybody to this Medscape event, Expert Insights on the Appropriate Use of NITs for Fibrosis in Patients with MASH. I'm Mary Rinella. I'm a professor of medicine at the University of Chicago and hepatologist, and I'm going to be moderating the discussion. I have the distinct privilege of having two colleagues who are really luminaries in the field. Those are Manal Abdelmalek, who is a professor of medicine at the Mayo Clinic, and Rohit Loomba, who's chief of the division of gastroenterology and hepatology and professor of medicine as well at the University of California, San Diego. So to start the discussion, I just want to outline why we are talking about non-invasive testing. And this is, of course, fairly obvious to those of us who take care of patients, but just some general things to keep in mind. Liver biopsy is fraught with many potential issues, one of which is that it really is only a very tiny fraction, about 1/50,000th of the liver. And so sometimes it's not completely representative of the entire liver. On a more sort of individualized basis, there is significant inter and intra-reader variability when we actually look at these biopsies under the microscope, and this has been particularly highlighted in the context of clinical trials. And in this picture, you see a ballooned hepatocyte that's got, I believe, 9 circles around it, because in this particular study, only one hepatocyte was identified by all 9 pathologists in the study as being a ballooned hepatocyte. And this is the quintessential finding to diagnose steatohepatitis. And then lastly, and actually most importantly, it's a safety issue. This can be associated with pain, of course, commonly bleeding, about 1 in 1,000, gallbladder perforation, about 1 in 250 or so. And then there's inadvertent biopsy of other organs. So these are all very important issues and reasons why patient advocacy groups and others really are shying away from liver biopsies in general. So these key limitations in histology that I just highlighted that have led to significant variability in our ability to determine whether a drug that's being studied for this disease is efficacious or not. That's been a significant problem, in addition to other issues such as the placebo effect. And all of these, particularly from a biopsy perspective, have led to very high screen failure rates in trials. And so we're hoping to move out of biopsy into NIT, non-invasive test based strategies for clinical trials in the future. So with that, I'm going to pass it over to Dr. Loomba, who is going to take us through a patient case.
Thank you, Dr. Rinella. It's really a pleasure to be working with you and Dr. Abdelmalek on this discussion on MASH and NITs. Take a look. So I'm going to briefly start with a case, a 50-year-old woman with obesity, type 2 diabetes, hypertension, presented to primary care, lives in a rural setting, had a recent ultrasound that showed fatty liver. On physical exam, chest is clear. On liver span, the liver span is about 18 centimeters on percussion. Her labs, ALT is 50 units per liter, AST of 40, albumin of 4.5, INR 1.1, GGT 40, platelet count is 200,000. She was tested for hepatitis C. Antibody was negative. Autoimmune serologies are negative, and hepatitis B surface antigen is negative. She had an ultrasound. Ultrasound shows echogenic liver with enlarged liver. So in terms of assessment, what should be done next for this patient? And the idea is based upon our practice guidance that Dr. Rinella, Dr. Abdelmalek, and I have been involved with. We start with the next step of doing a FIB4 assessment. This is a clinical prediction rule that utilizes routinely available blood tests. So you put in age along with AST, platelet count, and ALT. And this can give you a number. And based upon that number, we can stratify our patients whether at low risk for advanced fibrosis, intermediate risk, or high risk. So this is the 2023 ASLD, MASLD practice guidance. You start with a patient who has metabolic risk factors, such as our patient, and then you look at FIB4. The FIB4 is greater than 1.3, then you move for a second line testing or additional testing. And this could be done based upon a liver stiffness assessment by either a FibroScan or a MR elastography, or a blood test such as enhanced liver fibrosis panel. and that could be utilized. And then the patient could be referred to GI or hepatology care for further assessment. So in summary, ASLD NIT algorithm recommends starting with FIB4, followed by ELF testing or VCTE. Liver biopsy may be considered when there is diagnostic uncertainty, as may occur with discordant or indeterminate NIT results in the setting of a hepatology practice when the patient's already referred to us. But generally, with FIB4 followed by ELF or VCTE or MRE, we're able to risk stratify majority of our patients without needing a liver biopsy assessment. So this patient's FIB4 is 1.4. VCT is not available to the patient because this patient lives in a rural setting. So an ELF was ordered based upon the practice guidance. ELF, if it is 9.8 or higher, it is associated with increased risk of progression to cirrhosis. That's based upon previously published studies. This patient likely has advanced fibrosis and would benefit from specific treatment of MASH-related fibrosis. Now I'm going to pass the baton on to Dr. Abdelmalek to discuss principles of NIT assessment of liver fibrosis.
Well, thank you, Dr. Loomba and Dr. Rinella. It's always a pleasure to engage with both of you in these very important discussions in the field of MASH. And so as we talk about moving the field forward beyond the biopsy, there are key principles to recognize in regards to non-invasive tests. These tests really do need to be biologically plausible. They have to be surrogates that reflect the core biological processes that drive disease progression, with the understanding that fibrosis is the primary predictor of clinically related outcomes. They have to have a predictive value of meaningful clinical outcomes, how patients feel, function, survive, or progression to cirrhosis, decompensation, or death. They have to be consistent across studies and therapies. We have to really have a one-size-fits-all model, so the surrogates could be applied broadly to different drugs, different trials, different patient populations. And they have to certainly be standardized and reproducible in across sites, across vendors, across time points, so that there is durability in the use of these non-invasive tests. And of course, the feasibility in pivotal trials, the tests must be practical, scalable, interpretable across large multi-center trials, which are now global studies. So I think we can think about the non-invasive tests in three broad categories. The simple tests, which are calculator-based, that Dr. Loomba just shared the FIB4 index with us, but there are others, the NAFLD fibrosis score, the APRI score. There are proprietary blood-based biomarkers such as the ELF panel, which is really being more broadly used as a risk stratifier for cirrhosis, and other blood-based biomarkers. And then we have imaging biomarkers such as elastography, the standard transient elastography or FibroScan, but MR-based platforms that are being broadly validated in the use of clinical trials and clinical practice. When we talk about the guidances that have been issued and why specific non-invasive tests have been identified in these guidances, you'll see here that the FIB4 index has a very high area under the curve performance for advanced hepatic fibrosis, and it's been externally broadly validated, and it really has no cost associated with it whatsoever. It's a point-of-care assessment that any provider can do. And then the blood-based biomarker, the ELF test, also has the highest performance for advanced hepatic fibrosis, as well as F4 cirrhosis, and has also been the most broadly validated amongst the blood-based biomarkers in the space of MASH. Now, when we talk about moving beyond recognition of advanced hepatic fibrosis to what we are increasingly becoming interested in, which is the at-risk F2, F3 cohort of patients, which are currently being identified for pharmacotherapies, we need to combine these non-invasive tests together, and there are composite algorithms that combine both elastography with a blood-based biomarker such as the FAST score, which is VCTE, the CAP score, and an AST, or the MET-FIB score, which is the MR elastography liver stiffness of greater than 3.3 combined with the FIB-4 score, or even the MASS test, which is MR elastography with quantitative liver fat content in the mass. These are all calculator-based assessments, but by combining non-invasive tests, we have a higher probability of really defining that at-risk cohort of patients in the intermediate stage, not just at both spectrums of the disease. So how do we apply these NITs in our guidance? Well, as you could see here, it's all about risk stratifying in clinical practice those patients that have advanced hepatic fibrosis or cirrhosis, applying first the FIB-4 score, and if it is really less than 1.3, and in patients without metabolic risk factors, no diabetes, these patients really are low risk for having advanced hepatic fibrosis and can be managed conservatively and monitored serially and longitudinally. However, if the FIB-4 score is less than 1.3 and a patient inherently has increased risk for metabolic syndrome and type 2 diabetes, a second risk stratifier is warranted, and that could be the ELF score, VCTE, or MR elastography. And certainly if the FIB-4 score is higher than 1.3, applying that second risk stratifier, and then triaging patients accordingly such that patients who are identified to be at risk or have intermediate or more severe advanced hepatic fibrosis F3 could be identified for not only lifestyle modification, but pharmacotherapies. And those patients who have cirrhosis not only need consideration of multidisciplinary care, but need surveillance and monitoring for MELD score, timing for transplant, and surveillance for hepatocellular carcinoma, as well as varices. So the algorithms for identifying the at-risk patient, especially as we consider implementation of therapies such as resmetirom, there has been a recent guidance as to who to treat and who not to treat. Treatment of patients who have a VCTE of 10 to 15, a mildly elevated MR elastography, or any combinations that identify that at-risk patient could be considered for treatment. We have to be a little bit more cautious as these values get a little bit higher so that we can identify or consider treating those patients with F3 disease, but without risking treating those patients who clearly have more advanced hepatic fibrosis or cirrhosis, or potentially even portal hypertension. So I encourage everybody to really look at these guidance and these thresholds when considering treatment. But we do know that these non-invasive tests can now be utilized to evaluate treatment response. And much of this data was actually generated by Dr. Loomba, and we've grown to recognize that, at least with liver fat quantification by MR-PDFF, that more than a 30% relative reduction has been associated with MASH improvement and resolution. A drop of greater than 15 units of ALT predicts also MASH resolution and histologic improvement. And even an improvement in the MR elastography by MRE of greater than 15% from baseline can be associated with MASH resolution. And this also applies to VCTE and FibroScan at a threshold of approximately 30%. So we are learning how to utilize these NITs in clinical practice, not only for identifying patients who need pharmacologic therapy, but also for following them longitudinally for a treatment response. And with that, I'll pass it back over to Dr. Loomba.
Thank you, Dr. Abdelmalek, for this outstanding discussion on NITs and how we can utilize them in clinical practice to make treatment decisions today. So, patient comes back for a follow-up, and we've noted a change in ELF score from 9.8 to 11.5 after a few years. This patient comes back to the clinic. Based upon the data presented by Dr. Abdelmalek, if the ELF is greater than 11.3, then your likelihood of cirrhosis is pretty high, and that patient may be at risk for decompensation as well. So it suggests that the patient may have developed cirrhosis. Now, what would you be thinking about? This patient has approximately 20% risk of hepatic decompensation over the next 2 to 3 years and would potentially benefit from the following: a clinical visit with the hepatologist, ultrasound with AFP for presence of ascites, and also for hepatocellular carcinoma screening. Varicose screening, you might consider doing an endoscopy. Consider VCT or MRE assessment, because that can also help you understanding the overall risk in terms of concordance between two NITs. Get med labs to think about, at what point this patient might be needing a referral to a transplant center, an evaluation for presence of hepatic encephalopathy. That's mainly clinical evaluation. So I'll now pass it back to Dr. Rinella for a Q&A discussion.
Yeah, thanks, Rohit. So that's really, you touched on so many important points. I think one thing that I think is a question, certainly for me, is that sometimes when you're trying to assess a patient's risk, you maybe need to rely on more than one thing. For example, you can have, just to use liver stiffness as an example, sometimes liver stiffness can be quite elevated, and it's not because of fibrosis. So maybe you can speak to what other things you might think about and how you might, more accurately identify people. It's different fibrosis stages and exclude cirrhosis, for example, as well.
Thanks, Maru. I think, as we know, many a times liver stiffness, particularly on ultrasound-based modalities such as FibroScan, could potentially be elevated. So this could happen in overestimation in the setting of obesity, in the setting of acute inflammation, in the setting of a patient getting admitted to the hospital, may even have a right lower lobe pneumonia, and you can have elevations in liver stiffness in that setting. Patient with fluid overload, or patient with congestive heart failure. All these are conditions where you might have an elevated liver stiffness, not necessarily in the setting of cirrhosis. So I think ruling those out, would be, something to think about, and also putting an overall perspective on what's happening with the patient. In this particular setting, other tests could potentially be useful, and ELF might be useful. The other thing is, following patient and doing this when the patient in a steady state in outpatient. That's when I think liver stiffness assessment of FibroScan is probably most useful for thinking about whether a patient has, fibrosis or cirrhosis. ELF is particularly helpful as we look at whether the ELF is below 9 or below 9.8 or above 9.8, in thinking about concordance and having diagnosis for cirrhosis. FIB4 is another test that one could use, particularly in the setting the FIB4 is greater than 2.67 or greater than 3.25. The likelihood of stiffness read on the biopsy is more likely to be true. You were saying something, no?
Yeah. No, so with ELF, you can also sometimes see false elevations in the setting of a lot of inflammation too. Just something to keep in mind. And then maybe Manal, maybe you can comment on what modalities you are most comfortable with, or do you feel are most useful when assessing response to treatment, whether that's one of the new, now there are 2 FDA-approved drugs versus, or lifestyle intervention, for example. What do you use to assess if somebody's gotten better from a steatohepatitis perspective and also from a fibrosis perspective?
Yeah. So my approach to initiation and monitoring of pharmacotherapies is actually I will at baseline obtain a set of liver enzymes and a point of care. I use both VCTE and MR elastography. Our center does a lot of MR elastography and MR PDFF, but I'm also very comfortable using point of care. And I will see patients back for assessment of tolerability and compliance at about 3 months, recheck liver enzymes, and about 6 months I will repeat an elastography assessment and follow them every 6 months to a year thereafter. Usually those that have elevated liver enzymes will have declined. It certainly isn't helpful for those patients that have normal liver enzymes, in which case that I'm really relying on either a blood-based biomarker like the ELF or VCTE, because a good majority of our patients may have normal liver enzymes despite the presence of steatotic liver disease.
Yeah, that's a great point. Do either of you have questions for one another or me?
Yeah, I think one comment to make, especially as we consider the Fib4, and I'd be interested in both of your thoughts on this. It weighs very heavily in on age, and so it could risk under assessing for the presence of MASH in lieu of other variables in those that are young, or potentially over assessing the risk in those that are older than age of 65. So when I am seeing both spectrums of age and in the disease spectrum, I do tend to utilize a second non-invasive test to confirm the FIB4.
Yeah, I would say I do the same thing. So for the Fib4 for patients that are over 65, you can just increase the threshold to 2. But the performance of people under 35 is really terrible. I don't think Fib4 should not be used in young people because it really does not accurately identify people with significant fibrosis. And there are other caveats with Fib4 that we need to remember, that if you're applying it to a population with high risk of fibrosis, that the accuracy is less. Though we do want to be consistent in our messaging that perfect is the enemy of good, and we do want people to be doing Fib4s despite its limitations. Maybe you can close, Rohit, with any last comments.
Yeah, I agree. I think very nicely said, Maru and Manal. I think the dual approach and stepwise approach helps. Take a patient with a metabolic risk factor and start with a FIB4 assessment. Depending on their age, as Manal mentioned, you could utilize a slightly lower or a higher threshold. But remember 1.3. If it is greater than 1.3, then think about secondary testing. In this case, could be ELF or VCT or MRE. And then based upon that, you can make a decision or refer a patient to a hepatologist for further discussion. With that, thank you.
So with that, I'd like to conclude, but I wanted to thank everybody for their participation, and I wanted to just maybe raise, have some additional questions if my participants are willing to answer them. So maybe Manal, you can tell me a little bit about, in a patient that you're seeing like this. Say you have non-invasive tests that are not the same. So say you clinically think the person has more advanced disease, but their ELF is low, or their ELF and their liver stiffness tests are not aligned. So what would you recommend people do in that scenario?
I think we have to keep sight of the clinical risk factors in our patients. First of all, if a patient is over age of 50 with diabetes, and particularly long-standing diabetes, my uh, predictive value of advanced hepatic fibrosis is already high, especially if there's an enrichment of 3 or more metabolic features. So if I get a very low FIB4 score or something's off, I always follow it up. Patients who are significantly obese, and I'm getting broad interquartile ratios on my FibroScan assessments, and who are otherwise suitable for MR-based elastography measures, I will perform an MR elastography. And of course, as Dr. Loomba already pointed out, for other patients, we have the liberties. If those platforms are not otherwise available, you don't have point of care FibroScans, to send a blood-based biomarker like the ELF score. I don't use ELF as much, but certainly it is commercially available and can readily be used. And a threshold above 9.8 is a strong predictor of advanced hepatic fibrosis, and 11.5 even a predictor of clinical outcomes. So I think sizing it up based on patients' ability to undergo MRI and the concerns of other confounders that may inadvertently skew or falsely increase the liver stiffness, such as obesity or heart failure or other things.
Thanks. So maybe just to close, one last question. So we've spent 25 minutes talking about non-invasive tests and how to use them and how to identify people at risk and guide therapy and therapeutic decision making. So Rohit, maybe you can walk us through what scenarios would prompt you to actually do a liver biopsy in a patient like this, so that I think that so the listeners understand that occasionally we do need to do them still. So.
Yeah, I think it's really important because if you look at the entire NIT cascade, it's in this patient we did autoimmune serologies, but many times what happens is that you have a patient with elevated ALT and AST, they've got autoimmune serologies that are positive, they may be ANA positive, then we will do further testing, immunoglobulin testing might be done. We might do effectin. In those cases, if I have a diagnostic consideration that this patient may actually have autoimmune liver disease, autoimmune hepatitis, or if there's iron overload, in those settings, I might even consider doing a liver biopsy for differentiating what might be the predominant reason for this patient's, elevations in liver tests and liver disease. So I think that happens, I would say, probably 1 in 20 patients or so that we might consider doing. Another scenario where we might consider doing a biopsy is when you have discordance. For example, if you have a patient who had a fibroscan and MR elastography done at the same time as, Manal mentioned, and the fibroscan read is 20 and the MR elastography reading is, 2.7. It's not concordant. And then you look at their liver enzymes and they're, kind of mid-range. This is a patient who you might consider doing a liver biopsy. Another patient might be where you're thinking about this patient is 70, has a history of congestive heart failure, and you get a elevated liver stiffness. Now you're worried whether this patient has real stage 3 or stage 4 fibrosis, or this is related to chronic passive congestion. And in that setting, I also end up doing a liver biopsy.
So just to wrap up some of the take-home points from today's session, high-risk groups should be proactively screened for advanced fibrosis because they have a higher risk of decompensation in the future and would benefit from treatment. Screening should start with FIB4 in the general clinic setting and involve secondary testing in high-risk groups or settings, as we discussed, such as with the use of ELF or elastography. NITs can be used to detect or exclude advanced fibrosis, identify at-risk MASH, and assess the risk for major adverse liver outcomes. And then lastly, understanding of the NIT-based assessment of treatment response really does continue to evolve, although MRI-PDFF reduction of more than 30%, that's a relative reduction, and an improvement of ALT of greater than 17 units per liter seem to correlate the best with MASH resolution. All right, well, thank you. And I really want to thank Doctors Abdelmalek and Loomba for participating in this discussion. I hope everybody found it interesting and insightful. And thank you very much.
Thank you, Maru. Thanks, Manal. Bye-bye.